Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article Prognostic Relevance of Treatment Response measured by flow cytometric residual disease detection in older patients with acute myeloid leukemia by Sylvie D. Freeman et al. My name is Elizabeth Payetta, and I manage the Leukemia Translational Research Laboratory of the Eastern Cooperative Oncology Group, located at Montefiore Medical Center in the Bronx, New York, in the United States. My specialty is leukemia biology, including the study of minimal residual disease in the acute leukemias. In the article that accompanies this podcast, Freeman and collaborators report that the early assessment of response in patients with acute myeloid leukemia, or AML, older than 60 years of age, and treated on trial AML-16 provides powerful, independent prognostic information. Although almost half of older AML patients achieve a morphologic remission when intensive induction chemotherapy is used, more than 80% of remitting patients will eventually relapse and succumb to their disease. The root of relapses is the persistence of minimal residual disease, or MRD, that remains after treatment at levels too low to be detected under the microscope. The level of MRD after induction chemotherapy reflects the quality of the remission and therefore serves as a post-therapy prognosticator. Standard prognostic features present at diagnosis, including cytogenetic aberrations, gene mutations, and immunophenotypic characteristics, predict for the occurrence of MRD after therapy. However, within each conventional risk category, MRD status adds independent prognostic information. In other words, patients with favorable standard risk will do much more poorly if they remain MRD positive after therapy than favorable risk patients without detectable post-therapy disease, while patients with intermediate risk who become MRD negative with induction therapy will do as well as MRD negative favorable risk patients. Compared to pre-therapeutic risk factors, MRD represents the collective end result of all of the cellular mechanisms that determine a patient's response to a given therapy. Early MRD assessment in the treatment course allows for refined risk stratification by directing MRD-positive patients to intensified therapy, particularly allogeneic stem cell transplantation, while sparing MRD-negative patients procedure-related morbidity and mortality. Given our understanding of the limited clinical value of a morphologically defined remission and ample, though mostly retrospective data, suggesting that MRD has a decisive role in treatment stratification, one cannot help but ask what the reason is that post-treatment MRD status is not yet used routinely to dictate post-remission therapy. The answer lies in methodological aspects of MRD determination and the interpretation of MRD measurements. Currently, two methodologies are most commonly used for MRD quantification in AML: polymerase chain reaction amplification for leukemia fusion genes or recurrent gene mutations, and multiparameter flow cytometry. The few comparative analyses of these two methods in AML have found them to be equally effective in identifying patients at high risk of relapse. The biggest single concern with both methodologies is the lack of assay standardization. It is remarkable that despite the large variability in result interpretation and the definition of MRD positivity, all but one study published to date have found a significant association between MRD status and clinical outcome. This observation suggests that the prognostic value of MRD is robust and not easily swayed by technical aspects. However, the lack of standardized MRD quantification and established thresholds for defining MRD positivity hampers the application of MRD for treatment assignment in clinical trials. If we look at the Freeman paper, the whole confusing complexity of MRD interpretation becomes apparent. In that paper, multi-parameter flow cytometry was preferred over molecular MRD determination, given that older AML patients are less likely to present with molecular targets suitable for MRD monitoring than the younger cohort. Though a standard antibody panel was used to diagnose patients, 3 routine clinical laboratories alternated in determining the characteristics of leukemia-associated immunophenotypes, which were subsequently chosen to test for MRD. It is a well-known fact that flow cytometrists must be trained in the establishment of leukemia-associated immunophenotypes, and that the strategy for detecting low numbers of leukemic cells in treated patients requires experience and skill. Using routine clinical laboratories may have been the reason why the detection limit of their MRD assay was only 1 leukemic cell in 1,000 normal cells, and thus tenfold above the detection limit usually reached by flow cytometric MRD assays. While the authors state that the lower sensitivity of their assay could have limited the clinical usefulness of MRD results, they find their assay vindicated by the result of the statistical analysis, which demonstrated that MRD was a strong independent predictor of outcome. But is this conclusion justified? 2 facts need to be considered. First, although overall survival in trial AML-16 was better in MRD-negative patients, the 3-year cumulative incidence of relapse was 71%, thus very high. This observation suggests that the MRD-negative group in the Freeman study included patients who had not achieved a good quality remission, which can be explained by the low sensitivity level of their MRD assay. Second, while addition of the anti-CD33 antibody gemduzumab in AML-16 resulted in a significantly lowered 3-year cumulative incidence of relapse, Freeman et al. Did not find this improvement to be associated with a significant difference in MRD. This is in stark contrast to MRD measurements in the Alpha 0701 study conducted by the French Acute Leukemia Association, in which AML patients 50 to 70 years old experienced longer overall survival when treated with gemduzumab, which was paralleled by significantly lower MRD levels, thus better remission depth. In view of such discrepancies in retrospective MRD studies, what will it take to allow this prospective use of MRD in therapeutic decision-making? First and foremost, we need a standardized approach to MRD quantification, whether MRD is measured by flow cytometry or molecular analysis, and MRD interpretation. In the majority of published retrospective MRD studies in AML, MRD was dichotomized as positive or negative using a threshold of 0.1% of leukemic cells, which contrasts with the much lower level of 0.01% in acute lymphoid leukemia. In fact, anecdotal reports suggest that acute lymphoid leukemia patients with MRD lower than the threshold do more poorly than patients without any detectable disease. The apparently higher clinically relevant MRD threshold in AML may represent a true biologic difference between the 2 diseases, or may reflect more effective treatment strategies for eliminating MRD in AML. Once the threshold suggested by retrospective studies is consistently reached in all MRD laboratories, its clinical validity will need to be confirmed by prospectively treating such defined MRD-positive AML patients with more intensive and/or novel therapies. We must always remember, though, that the predictive value of MRD will change with every new treatment strategy. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.